Hi ladies, it's Dr. Sherbel. I want to make a video today to talk about an important topic that seems to be coming up a lot recently with my patients. And it was asked that I discuss diabetes and pregnancy, specifically gestational diabetes, but it's actually going to kind of be relevant to any diabetes and pregnancy. So to be clear, when we talk about diabetes, we talk about uncontrolled blood sugars. Blood sugars are controlled by a hormone called insulin. Insulin is released by our pancreas. We release it after we eat, and it helps our sugar go from our bloodstream and into our cells. So people with diabetes in general have insulin resistance, which means their body doesn't respond to it like it's supposed to, and they therefore have just higher blood sugar levels all the time. And over a long time, a high blood sugar level leads to chronic inflammation, which can affect the little tiny capillaries of our body, so the little tiny itty bitty blood vessels. And that's why you might realize, like, somebody who has diabetes, like a really bad case of diabetes, maybe they have wounds on their feet and their toes, which can never seem to heal well because it's the little tiny capillaries of the body that get the biggest insult. And over years, a long time, that can really insult the tissue. So that's why sometimes they might have a non-healing wound, or unfortunately, sometimes they start to lose maybe their toes because they can get such bad infections because their body can't heal because the blood vessels aren't effective anymore. So a lot of patients have diabetes before they get pregnant, and there's a whole set of concerns there. That's called pre-gestational diabetes. Gestation means pregnancy. But a lot of my patients have a hard time. I help women get pregnant all the time who have maybe polycystic ovarian syndrome, which I've talked about many times, because polycystic ovarian syndrome, I always say, it's kind of like saying pre-diabetes. So to review, these are girls that don't ovulate regularly because their sugars are not well controlled. So there's this whole discussion about polycystic ovarian syndrome that I have in a different video if you want to look back. But in summary, it's like saying pre-diabetes. So often if we can get their sugar working better, they have more regular ovulation and they're more fertile and able to conceive more easily. So a lot of times I will help women get pregnant by managing their glucose intolerance or insulin resistance, sometimes we'll say, and or polycystic ovarian syndrome. And all that equals a low sugar diet, increase protein in our diet, have a lot of activity, which helps lower sugar levels and inflammation, and to lose weight. So a lot of times women will become pregnant after being treated for polycystic ovarian syndrome, which is wonderful. So they'll lose weight and then they'll call me pregnant, and it's just so joyful. But then now that we're pregnant, now we're on to the next concerns, is that we want to have a healthy pregnancy. So it's helpful to get healthy before pregnancy, and it's important to stay healthy throughout the pregnancy. So I've learned in my career that if I address these concerns early on, that it can really lead to better outcomes at the end of pregnancy. So I didn't used to always do this, but I spent a lot of time in the first couple months of pregnancy talking to my patients about diet and exercise, and kind of saying, don't eat so much sugar. When I was pregnant, I just thought I could eat whatever I wanted and kind of went a little crazy. And I'm kind of mean to my patients. I say, you don't get to eat the whole row of Oreos. You just get to eat one Oreo for each hand. So all the more reason that we're pregnant that we want to have a healthy diet, because we imagine that we should be eating the same food that we put on our baby's high chair. So I wouldn't put a stack of Oreos on my baby's high chair. And so I want to feed myself the same way that I would feed my baby who would be sitting across from me. So I spent a lot of time talking about this, and this is preventative care. So one thing that we can identify is people at increased risk of gestational diabetes would be people who have it in their family, maybe their parents have it, first-degree relatives like brothers and sisters have it, and also women who have polycystic ovarian syndrome. So things that we can do if we're concerned is like screen early on, and it really does make a difference if we do testing in the first trimester. We can do a sugar test that we normally do between 24 and 28 weeks pregnant. So most women get screened between 24 and 28 weeks pregnant. They drink a whole bunch of sugar. It's actually 50 grams of sugar. I would say it's like syrup. It's kind of like the bottom of a snow cone, and you chug it really fast. And then we draw your blood 1 hour later. And we're trying to identify those women who don't process sugar well, and they're at increased risk of diabetes. If they fail the 1 hour sugar test, the next step is to often do a 3 hour sugar test. But honestly, a lot more the more I practice, the more I just encourage patients. I don't mind doing a 3-hour sugar test. It's a similar process where you drink a bunch of sugar, but this time it's over a 3-hour period. However, more these days, I encourage a patient to check her sugars as though she's a diabetic. So I give her a little device. She pricks her finger 4 times a day. It's called a glucometer. And it doesn't hurt to prick your finger. And they check it first thing in the morning and then 1 hour after each meal. And give a little recording. So I do that a lot, and I actually like doing that. And the patients do not have to. I offer them the 3-hour sugar test if they want. But I like them to check it 4 times a day because I've learned it leads to a well-informed patient, and she will automatically start self-correcting her diet. So if she realizes that when she eats, Captain Crunch for breakfast, and then 1 hour later her sugar is really high, then the next time she eats breakfast, she often will realize she can't eat Captain Crunch. And instead, she'll eat eggs. So these are various ways we can screen for gestational diabetes, but staying ahead of it, identifying early on, can really reduce bad outcomes later. And what are those bad outcomes with diabetes? So we talked about how it can really affect the little capillaries of your body. Well, the placenta is a sac of blood vessels. So I say all the time, the placenta is just a sac of little itty bitty blood vessels. So if the placenta isn't grown well, then the baby doesn't do as well. So risks of having diabetes in pregnancy are a really, really small baby, a really, really big baby, sometimes a big baby that can't fit out, or maybe their shoulders get stuck, or a baby that the placenta really can't seem to tolerate labor very well because the sugars are uncontrolled. So there's an increased risk of C-section. Unfortunately, there's an increased risk of stillbirth, preterm labor, because the placenta is inflamed from the high sugars. And then when the babies are born, there's a higher chance that they have more immature lungs, and they have to go to the NICU sometimes, and the babies themselves have a hard time controlling their own sugar because they themselves have very high insulin level because they've been responding to this high sugar level that they've been getting from their mother throughout their life. So now that the sugar from the placenta is gone, now these babies have a whole bunch of insulin. So actually, it's interesting. Their blood sugars can drop really low, and that can land them in the NICU. So this is a really complex topic. One thing that's really important for women to realize if they have diabetes prior to conception is that they have a higher risk of having congenital issues when they do conceive a baby. They have a higher chance of the baby having, for example, I've seen a really malformed heart, which is a really sad case because sometimes we don't find that out till their 20-week ultrasound. So just kind of summarize how we can help control the diabetes besides diet and exercise is various medicines. The main medicine is insulin, and strict glycemic control can really help with better outcomes for the pregnancy. There are some pills that you can take to help with blood sugar issues in pregnancy, and I am open to any conversation that will keep the patient and her baby healthy. But insulin is the best. If they get pregnant on some pills that we'll give, sometimes we give metformin, and that helps a woman with PCOS helps her conceive. If she's on it, a lot of doctors will continue her on it throughout the pregnancy. But oftentimes, if we don't get the sugars under control, we need to initiate insulin. So these are all really sensitive topics, and it's difficult to talk to women in general about sugars and their diet and their weight, but it's a really important topic if we want to be healthy enough to conceive and healthy enough to conceive healthy babies and have vaginal births at a full term of healthy babies. So I'm Dr. Sherbel. I could talk about diabetes for much, much longer. This is just something that's come up a lot in my practice, and it's something that I'm happy to manage. It requires a lot of attention and care, and that's what we offer at Sherbel Clinic, a lot of personalized attention and care. So come see me. I have a concierge obstetrical model, and I also really enjoy helping women understand these principles so that they can have healthy lives in general, but also have healthy conceptions so that they have healthy outcomes at the end. I'm Dr. Sherbel. If there's anything in particular you wanted me to talk about, you can go ahead and write a note right here on this message board, and we can address it. And I hope to see you guys soon. I work at Sherble Clinic. Have a good one.